Gandang hapon po sa inyong lahat. Thank you for staying on, and thank you to PIDSP to allow us to present what we have been working on for the past 2 years intermittently. Okay, so our guideline is on acute bacterial meningitis, and just as a backgrounder, there was a previous practice guideline which was finished ba ma'am, in 1998. This was previously convened by the PISMID. Unfortunately, it was not published, no? So since it was so long ago, it really needs updating. So a committee was reconvened in 2013 in line with PIDSP's 20th anniversary celebration. And we presented an interim guideline last year. And since then, we still did more search for articles and other data which would contribute into making these guidelines. We also held more workshops on critical appraisal of the evidence. And for this particular presentation, it would be sort of like your pocket recommendations, no? So it's more of a summary of all the recommendations that we have put together, because I'm only given 30 minutes to present. So the draft guidelines have been finished, and we are presenting it to you for your possible comments and critiques as one of the stakeholders who will use these guidelines. And if you have any comments, suggestions, and critiques, please email us at pidsp2009@yahoo.com. So this is only the summary of the guidelines. So I apologize to my co-committee members who worked so hard on this, who I have bullied into finishing, tumawa sila, in the guidelines. So this is our team, no? It is a joint committee of the PIDSP and the Child Neurology Society of the Philippines to come up with these guidelines. Our advisor is Dr. Estrella Paya Villar. Unfortunately, she's not here. And we also elicited the help of Dr. Isay Nilo, especially in the critical appraisal of the journals that we looked at. Okay. So it is a draft clinical practice guideline on the diagnosis, management, and prevention of acute bacterial meningitis. So we foresee still accepting comments until the end of the month, and after that we will be producing both a pocket guideline and a full manuscript of this guideline. And in looking at the evidence, we wanted to look at the level of evidence and paying more attention if there had higher level of evidence, especially in looking at systematic reviews, if they were available, and if they were not, looking at randomized control trials. If they were also not available, going down the line of the hierarchy of level of evidence. So the very bottom tier would be expert opinion if there are no articles or researches on this particular topic. And we've decided to use the WHO criteria for the assessment of strength of evidence, no? So for each question that we will have a recommendation, also a strength of evidence and a strength of recommendation, okay? So the level of evidence is high if further research is very unlikely to change confidence in the estimate of effect. The level of evidence is moderate if further research is likely to have an important impact on confidence in the effect. The level of evidence is low if further research is very likely to have an estimate of effect and is likely to change the estimate. And very low if any estimate of effect is very uncertain. So we have a strength of recommendations also, which we adopted from the WHO assessment criteria, no? The strength of recommendation is strong if the panel is confident that the desirable effects of adherence to the recommendation outweigh the undesirable effects. The strength of recommendation is conditional or weak if the panel concludes that the desirable effects of adherence to this recommendation probably outweigh the undesirable effect. Okay? And no recommendation is if further research is required before any recommendation can be made. Okay. So we divided it into diagnosis, treatment, and prevention. And I'm jumping right into the recommendations. No more backgrounder or epidemiology of meningitis due to the lack of time. Okay, so let's go into diagnosis. So what are the signs and symptoms for you to suspect acute bacterial meningitis? The recommendation was no single or combinations of signs and symptoms are diagnostic of acute bacterial meningitis. Strength of evidence is moderate and recommendation is strong. But there are some items that we already know that, especially in neonates, where we have very non-specific signs and symptoms in a systematic review of neonatal meningitis, the most common symptoms reported in neonates are fever, irritability, poor feeding, and seizures. In another systematic review by Curtis for children, the most common signs and symptoms seen were bulging fontanelle, neck stiffness, seizures, and having seizures outside the febrile range. Okay. So a very important question, what is the definitive test for bacterial meningitis? So the recommendation is that CSF culture is the gold standard for the diagnosis of acute bacterial meningitis. The strength of recommendation is high. Strength of evidence is strong. Okay, and if there was a study, a large study which showed that without prior antibiotics, you actually have a high yield. CSF culture is positive in 95% in those with H. influenzae meningitis, 87% positive in those with pneumococcal meningitis, and 80% positive in those with meningococcal meningitis. So what we really have to emphasize, that doing the lumbar puncture is very important. It's something we should not skip unless there are contraindications to doing a lumbar puncture. So these contraindications include signs of increased intracranial pressure, shock, and extensive or spreading purpura after convulsions have been stabilized, coagulation abnormalities, a low platelet count of less than 50, those receiving anticoagulant therapy, having a local infection at the LP site, respiratory insufficiency, or radiologic evidence of raised intracranial pressure. So all must be considered in deciding to do an LP, but treatment should not be delayed if the procedure cannot be done. So what we're emphasizing here is that time is of the essence. If there is a contraindication and you highly suspect acute bacterial meningitis, start your empiric therapy. So evidence is moderate and strength of recommendation is strong. So how will you differentiate acute bacterial meningitis from other CNS infections? So definitive diagnosis requires your culture and the CSF analysis. Unfortunately, a normal CSF analysis does not rule out bacterial meningitis, especially in the neonatal age group. However, a CSF protein of more than 1 gram per liter, a WBC of more than 100 with predominance of neutrophils, and a sugar concentration of less than or equal to 40% is indicative of bacterial meningitis. Okay. So this is the table that we will be placing in our recommendations. So let's just zero in on bacterial meningitis. Having neutrophils of 100 to 10,000, Lymphocytes are usually less than 100 cells. The protein is usually more than 1 gram per liter, and you should get the glucose of both your CSF and serum glucose, and the ratio of the CSF to blood glucose is usually less than 0.4. Okay? So, what are other ancillary tests, especially if you cannot do a lumbar pap, no, in the diagnosis of bacterial meningitis? There are some ancillary tests which will just help distinguish if it's bacterial or viral, and other ancillary tests would really point to a specific etiology. No? Okay. So your CBC, we hope, helps distinguish between a bacterial and a viral etiology for your CNS infection. And the recommendation is that CBC alone should not be used as a basis for starting antibiotics. So if you have signs and symptoms of bacterial meningitis associated with neutrophilia and increased serum CRP, these three are highly suggestive of bacterial meningitis. Don't have time, I'll just skip some of the evidence presented. Okay. How about the blood culture? So it is imperative that you do a blood culture. In patients suspected to have bacterial meningitis, blood culture should be performed prior, so the timing is also important, prior to starting antibiotic therapy. Okay. The serum and CSF C-reactive protein. No? So there was relatively a large amount of data seen for this, and serum and CSF CRP are useful in confirming and excluding bacterial meningitis, meaning a high serum and CSF CRP would more likely be bacterial meningitis. Okay. So since this is something not often shown, I decided to show the data for this. No? This is a combined data from some systematic reviews and trials. It had a high sensitivity for your serum CRP, and even higher sensitivity for your CSF CRP. And combined, if both are positive, highly sensitive, highly specific, very high positive likelihood ratio, and very low negative likelihood ratio, which are things that we want in a diagnostic test. And then you tell me, oh, there's no CSF CRP in our hospital, blah, blah. The reason why we want to bring this out is maybe there's some entrepreneurs out there or people in the laboratory who would consider putting these in your lab, no? Since they seem to be very useful tests. How about PCR? No? So there are tests which simultaneously detect, depending on which ones you use, simultaneous detection of strep pneumoniae, Neisseria meningitidis, and H. influenzae. So the PCR is utilized to amplify DNA from patients with meningitis, and, oops, why is it like that? So actually the recommendation is that if it is available and the patient can afford it, it is a very useful test, especially if the CSF culture is negative. So again, no, combined data from several studies showed high sensitivity, high specificity, good positive likelihood ratios, 9.5 to 55.6, and very low negative likelihood ratio, something that we desire in these diagnostic tests. Now, our old latex agglutination tests, are they still useful? Looking at the data, latex agglutination tests should not be routinely used in the diagnosis of bacterial meningitis. So if your patient is culture positive, no, it's likely that they will be latex agglutination test positive. But we're looking at the subgroup who are culture negative, and there usually is a very low sensitivity for culture negative meningitis. And in many of the guidelines also, they said that decisions on whether or not, decisions on treatment are usually not affected by the results of your latex agglutination test. This is something new. Things that are new are usually expensive, no? So, but they showed good data for procalcitonin. So procalcitonin, if positive, is a good test to differentiate bacterial from viral meningitis, and had better performance than the CRP. In situations where a CSF analysis could not be done immediately, it may be used as a basis to start antibiotics. However, it should not replace CSF analysis and culture in the diagnosis of bacterial meningitis. We say this because, of course, our patients may have limited resources, and if you have to choose which test to do again, it should be your CSF analysis and culture. Okay. So for this particular slide, there was voluminous data put in here, okay, for each line that I will say. Okay, so what are the most common pathogens of acute bacterial meningitis in the different age groups? And of course, we really looked more at the local data rather than the other data done abroad. For 0 to 2 months, the most common etiology was gram-negative bacilli. Okay, so group B strep was found here and there, but it was not very common, nor was Listeria monocytogenes. For patients more than 2 months to less than 5 years, still the most common etiology of meningitis was H. influenzae and strep pneumoniae. For those more than 5 years old, the most common was strep pneumoniae. Neisseria meningitidis was not a common cause. They may occur in epidemics, okay, and are usually caused by serotype A or B. Was there any sign and symptoms suggestive of a specific etiology? No, there was not. There is no sign and symptoms suggestive of a specific etiology except for your meningococcal meningitis, where you have your rash, impaired consciousness, and meningisms. And there was 3 important clinical features in one particular study, which was very common, was leg pain, cold hands and feet, and abnormal skin color. More of shock, more signs and symptoms of shock also. Okay, so let's go to treatment. Okay, so this is one of the slides where we have a little tussle on what we would recommend, no? So, kaya ang daming or. So what are the empiric antibiotics for neonatal meningitis? So it is ampicillin or cefotaxime or ceftriaxone plus an aminoglycoside. Which will you choose? It depends on your local resistance pattern. Some note on ceftriaxone. No? Looking at all the guidelines, the default 3rd generation cephalosporin which they use is really cefotaxime. Why? No? Because we are very careful in giving ceftriaxone, especially in premature neonates and those who are jaundiced, okay, because we know that ceftriaxone can displace bilirubin from serum albumin and can cause kernicterus. Also, if the neonate is less than 28 days of age and are receiving calcium-containing IV solutions, this is also a contraindication for ceftriaxone, especially if you have to give the calcium and ceftriaxone within 48 hours of each other. No? So there is a risk of precipitation of ceftriaxone combined with a calcium salt, and fatalities have been reported in neonates who received ceftriaxone and calcium-containing IV solutions. So which neonates can receive ceftriaxone? If the baby is premature and is already more than 2 weeks of age and should be anicteric, no? Hindi pwedeng jaundice. Also, if the baby is of term gestation and the indirect bilirubin is less than 8, and the baby should not be receiving any calcium-containing products. Okay? Okay. Next. Sorry, this should be 2 months. What is the empiric antibiotic therapy for patients 2 months to 18 years of age? Okay. Recommendation is ceftriaxone or chloramphenicol. Okay, so this is, in a sense, a change that we are no longer recommending ampicillin. So looking at the present resistance patterns of the most common etiologies of bacterial meningitis for Streptococcus pneumoniae, and this is Philippine data from our DOH and Dr. Carlos. Okay, these are, if I remember right, these are meningitic breakpoints already. No? So 5, the resistance rate for penicillin is 5%, for chloramphenicol 3%, and 0% for your ceftriaxone. For your H. influenzae, it has a high resistance rate for your ampicillin at 17%. And remember, you really need high levels of ampicillin in the CSF not to be effective. Your chloramphenicol is, the resistance is 7%. There was also a Cochrane systematic review, no, comparing third-generation cephalosporins versus conventional antibiotics. Conventional meaning ampicillin plus chloramphenicol, ampicillin alone, and chloramphenicol alone. And there was no statistically significant difference between the groups with regards to risk of death, risk of deafness, and risk of treatment failure. Sorry, that's risk of treatment failure. But there was a slight difference in sterilizing the CSF after 10 to 48 hours, wherein your third-generation cephalosporin had an advantage, although seemingly was not significant in having a difference in the risk of treatment failure. Also, there was a higher risk of diarrhea in patients given third-generation cephalosporins. We also looked at some retrospective data, local data for H. influenza B. Okay, this is a study done by Dr. Saiton in PCMC, and they looked at patients with invasive H. influenza type B disease, majority of which had meningitis. And even at that, in that time period, ampicillin failures were very high at 67%, lower chloramphenicol failures. The combination of ampicillin and chloramphenicol also had a high failure rate, and your chloramphenicol fared better than your third-generation cephalosporin failures at 38%. For strep pneumoniae, the ampicillin chloramphenicol combination was okay in 51.7% of patients. So discharge improved. Baliktad naman to. These are discharge improved. So less than half were shifted to a cephalosporin. And for the few patients at that time who were given a third-generation cephalosporin, all of them were discharged improved. So, okay. So which is why, just going back a little, why we are confident that the best recommendation would be Ceftriaxone or chloramphenicol. Okay, so what if you have an idea of what specific pathogen your patient has? Maybe you have a gram stain, okay? Maybe you had a positive gram stain for gram-negative bacilli, or maybe you have a positive PCR for a specific pathogen, yet you don't have the sensitivity yet, okay? So of course, if you have culture and sensitivity, then that should really guide you. So for E. coli, meningitis, which are more likely to be in neonates, no? The default third-generation cephalosporin would be your cefotaxime. But if there are no contraindications, then you can give ceftriaxone, and the total duration of treatment would be 21 days. In the rare occasion that you may have group B strep, still cefotaxime is the first-line treatment to be given for 14 days. For patients with H. influenzae, the first-line treatment is ceftriaxone, okay, and alternatives are chloramphenicol or cefotaxime to be given for 10 days. For strep pneumoniae, no, which are mostly still sensitive to penicillin, penicillin is the first-line treatment. For N. meningitidis, penicillin is still the first-line treatment. Okay. Unfortunately, we do not have any local data for susceptibility patterns against group B strep, so the recommendation was based not on local data, but from data abroad. So the question is it really that there is no group B strep, or are we doing something wrong that we're not able to grow it? No? So some studies have been done to see if we could improve the yield in obtaining or isolating this particular pathogen. So this is for the resistance for Neisseria meningitidis. No? So this is not in your usual ARSP report. Dr. Celia Carlos kindly gave us these data, and no resistance was seen for any of these antibiotics, penicillin, ceftriaxone, chloramphenicol, which is why we are still recommending penicillin for your Neisseria. So the recommended duration of treatment for acute bacterial meningitis is 10 to 14 days if you don't know what the etiologic agent is. I'm going fast now because I have 2 minutes and 21 seconds. So what are the indications to shift to another antibiotic agent? Okay, if there is poor response within 36 to 48 hours. No? So don't change your antibiotic every 24 hours. If there's clinical deterioration or drug intolerance, or there is resistance isolate, there is a resistant isolate based on cultures and clinically compatible with the patient's clinical course. Okay, can you use oral therapy? In general, we do not advocate switching from intravenous to oral antibiotic therapy due to the inability of most oral antibiotics to reach therapeutic levels in the CSF. There is only one exception, your chloramphenicol. You actually have higher bioavailability of your oral chloramphenicol compared to your IV. No? So it may be considered in patients more than 3 years old if the patient has improved on IV therapy. So this question was probably the one we debated on the most. We spent the most time here, and this may possibly change if new evidence arises. No? For neonatal meningitis, dexamethasone or steroids has no role, no, when you treat neonatal meningitis. We have a limited indication for the dexamethasone. It's only for children less than 5 years of age wherein Hib meningitis is suspected. And the timing is very important. Give it shortly before the first IV dose of antibiotic, but if you're not able to give it within the first dose, as much as possible, give it within the 4 hours, but do not give it anymore if it's after 12 hours from starting the antibiotic. Can you give me 5 more minutes? Jack and Poy. Okay, so the reason why it has a very limited indication, no? Although there was some significant protection against death, no? The confidence interval was very near 1. No? It was already 0.98. So really, was there really an effect or not? Okay. There was non-significant reduction in mortality of patients with meningococcal meningitis, so this was insignificant. There was no effect on mortality in H. influenza meningitis, but the only good effect was in reducing hearing loss. Okay? Okay. Also, sorry, did I put that in? Part of the Cochrane review showed that there was no significant effect on mortality for corticosteroid-treated patients for patients in developing countries. So where are we? Are we developing, not developing? We're in the middle of the road. We're somewhere in the middle, no? So ito yung pinag-aawayan namin na saan ba talaga tayo? And there was also one paper, although the sample size, of course, was much smaller than the large systematic review, which showed that dexamethasone or glycerol did not prevent hearing loss. Okay? So if you look at our strength of evidence was moderate, and the recommendation was only conditional or weak. Okay? So very limited indication for Hib meningitis. And we were also weighing risk-benefit. Is there a big risk for giving a short-term dose of steroid? It seemed in the systematic review, the adverse drug reactions was very low, no, for those given steroids. Okay. How about fluid therapy? Should you limit fluids during therapy with acute bacterial meningitis? We recommend give full volume maintenance fluids and do not restrict unless there is evidence of increased intracranial pressure or increased antidiuretic hormone secretion. Okay, so prevention, I can do this in 2 minutes. Is there a need to follow up antimicrobial carrier state? Meaning, in the index case, no, who has the infection, should you give antibiotics to eradicate the carrier state? Okay? So for the index case, to reduce secondary cases, yes, there's a need for follow-up antimicrobial therapy. Okay? For patients who had meningococcal meningitis and they were not treated with ceftriaxone, you should give this prophylaxis to eradicate the carrier state, and I will show the recommended antibiotics in a while. In those with Hib disease, okay, for children under 10 years of age, they also should receive rifampicin chemoprophylaxis to eliminate the carrier state. Okay. So what are the indications of prophylaxis among close contacts, and what is the drug of choice? Rifampicin is still the drug recommended for household contacts and child care contacts if of a case of Hib meningitis, if there is an infant less than 2 years old or an immunocompromised patient in that particular household. No? And rifampicin, rifampicin is still the drug of choice. Who qualifies as household contacts? No? Those with prolonged close contacts with the index case in a household 7 days prior to the index case. No? Living or sleeping with the same house, boyfriend, girlfriend, and sharing a dormitory or flat with the index case. What are child care contacts? Those with sharing with the index case any situations where children less than 5 years are cared for with other children 7 days prior to the onset of disease. How about for Neisseria meningitidis? No? What is the prophylaxis among close contacts? Okay, you only give it to those at high risk. Who are the close contacts? Household contacts, especially those less than 2 years of age, child care contacts. Okay, for physicians, no, it's always that we panic when there is a meningitis case in the ER. Only those with direct exposure to the index patient's secretions through kissing or through sharing toothbrushes or eating utensils, mouth-to-mouth resuscitation, unprotected contact during endotracheal intubation anytime 7 days before onset of illness. So really just close contacts. If you're on the flight, in a flight more than 8 hours, kung pumunta lang kayo sa Boracay, hindi kasama yon. So, chemoprophylaxis, so these are the drugs, rifampicin, Ceftriaxone, and ciprofloxacin for close contacts of patients with meningococcal disease. So vaccines, we recommend, inulit na naman yung oras ko, HIV vaccine and pneumococcal conjugate vaccine to prevent acute bacterial meningitis. Now, in meningococcal disease, vaccines have a limited role in outbreak situations. No? So, wait na lang for the recommendation of the health authorities. Okay, for prevention of transmission, okay, the current guidelines, HICPAC guidelines should be implemented to prevent transmission. Okay, and you can find that on this website. Just to emphasize that you don't need an isolation room, no, for meningitis patients, but a single patient room will suffice. Or in a ward, they should be at least 3 feet apart, separated by a curtain. Okay, so that was, so just to sum up, the old news that we know already since before are that neonates present with non-specific signs and symptoms when they have bacterial meningitis. LP for culture and CSF analysis are essential for a diagnosis and treatment, and CSF culture is still the gold standard. The blood culture is still an important ancillary test, and the HIV vaccine and the pneumococcal conjugate vaccine are important in reducing the burden of disease. What is new? Serum and CSF CRP, procalcitonin are useful in differentiating bacterial from viral meningitis, and so is PCR in identifying bacterial pathogens. Gram-negative bacilli is the predominant pathogen in neonatal meningitis, but the local sensitivity patterns may vary even within the Philippines. Ampicillin is no longer recommended as empiric therapy for patients more than 2 months old, and ceftriaxone and chloramphenicol are the drugs of choice for empiric therapy in those more than 2 months with acute bacterial meningitis. Thank you to our team very much for preparing this, and we will be coming up with the pocket guidelines soon. So email us if you have any critiques, comments, or suggestions. Thank you very much.